I highly recommend you use gait belts. Some facilities are gonna require it. For my lab practicals, this is a critical safety element. If you don't use your gait belt, you fail the transfer, no matter if you got technique right or not. So you put gait belt on first for all transfers. I've had students who've gone out in clinical and instructors don't use, the fieldwork educators don't use gait belts and they'll ask for them. It's a good idea. I have done transfers before, emergent transfers without a gait belt, and actually had my finger go through somebody's underwear because they start to go on me and I'm grabbing and my finger went right through their underwear. Okay, they didn't fall, I was able to stabilize them, but you're at risk. This gives you some leverage. Okay, so the first thing you're gonna do is put gait belt on. There are various types of gait belts. There are some gait belts that snap. There's some gait belts that have a coating for cross-contamination, as you see, because they're easily able to clean them. We're going to be using cloth gait belts with the teeth, mouth. When you put a gait belt on, you always go through teeth first. The teeth are going to grab the material and hold it in place. So you get it through the teeth, and then you put it through the rest of the gait belt ring, okay? When you put a gait belt on, you want to put it on snug enough that you can get 2 fingers under. When you stand, gait belt will become loose, okay? So a person's not going to come into standing, you don't have to worry so much. If you stand, it's going to become loose, so you might need to tighten it when they stand. We have to be mindful of people who are very bosomy. So women who have large breasts, putting the gait belt at the belly button, you have to be mindful of that, and you have to remove the breast, not off the chest, but you have to move the breast up and go under your breast and put the gait belt on, okay? If a person has tube feed, they have drains. I've had clients who've had transplants and they have major sutures in the abdomen. I had a guy who had he had a transplant and they couldn't close him up because there was so much swelling, and they had to leave him open with dressing and a mesh, so we couldn't use a gait belt over his tummy. You can put it above the pecs, above the breast. You have to be careful in doing this because if gait belt shifts as you're using it, what happens?
Right.
It will affect brachial plexus. What happens when we damage brachial plexus? Many things. The person can have dysfunction in upper extremity, right? They may have some nerve damage and not be able to use their arm if we damage brachial plexus. So we don't want to. We never pull under the armpits. We never grab people under the arms and transfer, right? Never, 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 never. When we're using gait belt, we want to make sure it's nice and snug so it doesn't slide up under the armpit, okay? So it doesn't happen often, but sometimes you can have clients that you can't put it around the waist. You could put it maybe a little bit lower, but it will shift up a little. So you have to be mindful of tubes and lines and surgical incisions and things when you're transferring your clients. So you guys each can grab a gait belt today when you start doing your transfers. We'll do that in a little bit. So always put on your gait belt. Okay, so what we're going to start with today is we're going to start with some bed transfers, mobility, and some dependent transfers. I need, my neck is bothering me a little bit from lifting, so once I show you guys, I'll probably have a classmate re-demo. So can I use you? She's a little light person to do some mobility. So we're going to, we did our diaphragm already. Go ahead and lay down. We're going to use a sheet to move a person up and down in bed. So the person doesn't have the ability to bridge and push self forward or down, so we're going to use a draw sheet. Show you how to do that. We're going to do it. So we take 2 people to do the transfer typically. If you ever get in a jam and you feel like you can't safely move someone, you ask for more assistance. You can ask for additional staff to come and help. Okay, so you guys might want to come a little bit closer for those of you that are behind me so you can see. When I move a client, of course you're going to tell them what you're doing. When I move a client, I want to use what they've got. So if she can bend her knee and dig in and help me, can I take the foot off? Then I want her to do that. So if she can bend her leg, and I can say, bend your leg for me, and we're going to use your heel. She can use her heel to dig in to help me with her rolling. And if she can't, I'm just going to kind of reach back. You're going to reach back for the pelvis, for the buttocks, and go out the scapula and move her that way. So these are the larger joints, and I can move her easily. Okay, even if she was a larger person, I can move her more easily that way. So stay right there for me. And so I'm going to look at the sheet, and I'm going to try to kind of divide it in half lower and half upper body. Kind of tuck it in like we did the brief. Tuck it under her. And I want about half and half on each side. And then I would help her come back for me, roll back. So even if she can't do it, I'm going to ask her to, because someday she may surprise me and attempt, especially if we're doing therapy together. You can straighten this leg up. Now let's bend this leg, and then we're going to roll some more, and I'm going to unball the sheet. Who would like to come over and help me transfer? Help me move her. Everybody's going to be doing it anyway. Okay, so if it's a bed, we have a person on each side, which is better. But sometimes we're in the gym, we're on a mat, and the person has to move. So you're going to get up on your knees on the mat, get in close. You choose a person who's going to be the person who's going to do the counting to initiate. So, Kayla, what we're going to do is we're going to scoot you down in bed. I know you're way up high, so there may be reasons that we have to reposition her. When I transfer, I'm going to use good body mechanics. I'm going to have a wide base of support. I'm going to use my quads. I'm not going to do straight knee. I'm not going to bend with my back. I'm going to squat. So you can really feel your quads activating when you do that. So I'm going to do a nice squat. We're going to grab the sheet on the count of 3. 1, 2, 3. I'm going to scoot her down. Okay. Now, they're actually something called slippery sheets, which is almost like a parachute-like material, and you can just go shoo, and the person moves up and down. You don't even have to lift them up at all. They just go zoom, and they don't get any shearing from it, which is one of the benefits of it. All right, so we're going to move back up in bed and get you comfortable on your pillow, Kayla, okay? So we're going to grab the sheet, bend, 1, 2, 3, and transfer. Woo! It's harder when you're the person on the mat, okay? Okay, so that is your dependent assist with bed, with repositioning bed. Thank you. You still need me? We're good. Thank you. Now, there are various ways that we train people in bed mobility, depending on their skill level and any precautions they may have. Now, when we're a person has the ability to reposition, then I'm going to want them to reposition themselves in bed. So if I'm scooted down, I'm going to see at first if they can scoot. So I'll ask them to bridge and scoot. So ideally, we want them to come up with both feet, dig elbows in, lift, and lift their tush and scoot. So we're going to bridge. This is bridging. So when a person is able to bridge, what can happen now? What would be easier? Like changing, putting a clean brief, wiping fanny, of course repositioning. So bridging is important. So if a person is being dressed bed level because they can't tolerate sitting to get dressed, maybe their sitting bounce is really bad, if I want to put pants on them and they can do this, I can get them up a whole lot easier. And it's less energy than doing this to pull pants up, right? So anytime you can help a person bridge, to be clean, to scoot themselves in bed, to pull their pants up, you want them to bridge, okay? And it's just good practice too, it's good for strengthening. This requires much more effort on both parties' parts to do the back and forth rolling. So a person can bridge and scoot unless they have precautions that's prohibiting them from doing it. When I teach people to roll. It's a very basic skill needed for cleaning and dressing, getting on the bedpan, and also getting out of bed. So when I have a patient who doesn't have any restrictions and I'm working on bed mobility, I have them bend the leg, the opposite leg from the side they're rolling to. Okay? I have them bring their arm across their body. If the arm is left hanging at the side and I start to turn, gravity is pulling me in what direction? Back to where my arm is. So I want the arm to come across body. So I'll tell them, bend your knee, dig in with your heel if you can, reach across and grab your bed rail if it's indicated. People are going to go home and don't have bed rails, like spinal surgeries, going home the next day. I won't let them do it. I'll tell them to grab the mattress. Grab the side of the mattress or the bed rail, depending on the circumstance, and come into side lying. Okay? Now if I have no restrictions, I tell them push through your elbow and your hand. So elbow that's on the bed, push through, and your hand. Bring legs down together and start to push with elbow and hand and come into sitting. Okay? So that's the easiest way to get out of bed for people who don't have restrictions. And that's how I train them for bed mobility. You may have clients who have restrictions with bed mobility. Spinal surgeries patients have restrictions. No bending, lifting, twisting. For that patient, I'm going to teach them a little different. They have to keep shoulders and hips together. We want spine in neutral, not twisting, right? So we have to do this slowly with them and instruct them so that they don't break precautions. I would like for them to bend their knee again. It gives them some leverage of the side opposite where they're transferring. Excuse me. And tell them keep hips and shoulders together. Now begin the process of rolling like you're a log. This is called the log roll. Now they're not going to bring the arm across their body while their pelvis is straight, right? Because we're twisting spine. So they're going to have to bring the arm and leg together. Arm and leg together. Come on the side. And then we're going to slowly start coming up and bring legs down. And we got to do it slowly, 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 slowly. So we can keep the hips and the shoulders together. Okay? So that's for a person who has to log roll. When it's time to get back in bed, we're going to have the spinal surgery patient go down on elbow, keep the shoulders and hips together, bring legs up. Once they're inside lying, then they will come into supine with shoulders and hips together. Okay? Another case that may be different is with a total hip replacement. So the total hip patient cannot adduct, correct? So you are going to one person is likely to have their adduction wedge in. So this is designed to keep the person from adducting. The person has a posterior spinal surgery. So this is designed to keep them in adduction. Some surgeons will let the person side lie with adduction wedge in, but you have to side lie on surgery side. We tend to avoid it, though. We don't encourage it. So a person needs to be changed, you know, a couple pillows between their legs or their adduction wedge. You can have them roll on the surgery side for cleaning. Some people can't sleep on their backs. That would be allowable, but it's discouraged. And this isn't really comfortable. I'm so sorry, guys. I'm choked up.
What's the water?
I don't know why. Might take a drink in just a second. So for this person, we're going to have them come into long sitting. This is an example of long sitting. Not everybody can long sit. Sometimes people are tight in their hamstrings, and when they long sit, it's uncomfortable. But for the person who has total hip, they don't really have a lot of options. So the person in total hip is going to come up into an inclined position. You will have removed the adduction wedge at that point. So you're going to instruct them to come up, not into full long sitting, but slightly inclined. And they too are going to keep their hips and shoulders together and the legs apart. So hips and shoulders are going to move together, but our hips are going to be apart. So you're going to have them start to turn, and they're turning. As I'm turning, you see my shoulders are staying with my hips. And then when they get to a seated position, you can have them lean back and scoot forward and scoot themselves out. Okay? So they can bend their knee. It's fine for them to bend their knee. When the leg is outstretched, though, it kind of eliminates the tendency to flex too far, because remember, with the anterior and posterior pelvic, posterior approach to total hip, they can't bend past 90. They can't bring their leg up or their body down. So having it in extension can help thwart that a little bit, but they can bend their knee. They just need to lean back a little bit. Excuse me. Okay, when it's time for them to get back in bed, if they're already seated on the edge of the bed, you're going to have them keep their legs adducted, and you're going to have them start to turn, and keep the hips and shoulders together, but legs apart. So, Debbie, want to come over? Oftentimes, if you're the first person to see them after surgery, and it's time for them to get out of bed, they'll be a little fearful. So the person has abduction, wedge in, and I'm going to instruct them, we're going to get out of bed, Devin. So what I'm going to have you do is I'm going to push up on your elbows in a few minutes, come into like you're sitting up, long sitting in the bed, not all the way, and And then we're gonna move your body towards me, keeping your shoulders and hips together. Now, what'll happen a lot of times, it'll be painful and swollen and fearful. When that occurs, I give support just above the ankle and just above the knee. Okay, go ahead and push up for me. Good. Now we're going to move with your shoulders and hips together, and I'll hold your leg as you go. So you're going to come towards me. Now this is good because I can control the adduction. Like I'm not letting her adduct. And also, she's a little less fearful. Now, she's not going to go home doing this, right? So eventually we want to back off, but sometimes that's the case. I'm going to let your leg drop. I'll be like, no, let it drop. You may have to kind of hold it for it a little bit. So scoot forward, Daly. Kind of come up for me. Good. You can come up a little bit. Good. Keep yourself nice and straight. Now lean back for me and a little bit and scoot your hips forward. So we don't want her doing the scoot because she's rotating internally, right? So we don't want her to do the scoot. We want her to, there's different ways you can move in bed. Scooting is one way. We don't want that for the hip because she's going to be tempted to internally rotate. So what we want her to do, and some people who can't scoot, we have them do, is to lean back slightly and thrust the pelvis forward. So lean back slightly and thrust the pelvis forward. They don't have to go down quite so far. And then that can help a person get to the edge. Okay, so with total hips, she's going to slightly lean back and thrust her pelvis forward, and that'll help her get to the edge. So if she's not a total hip, and we're trying to get to the edge of the bed, she can switch side to side and scoot her bottom. Please scoot down just a hair for me. Now, if she isn't able to do that, and we're working on it, I can reach back and grab her pelvis and scoot one side and another, and one side and another. We can do that with any kind of transfer if she's not able to shift her hips. Okay, see that? Again, we can lean back and have her slide forward, and that can be for different diagnoses. Hands on the mat. Now lean back a bit and scoot your hips forward for me. So the leaning back, your pants are grabbing.
Yeah, they are. In my skin.
She's sticking. Yeah. So that's another technique. Scoot back for me a little bit more. Now, this technique we would not use for people who have balance issues, but we could have a person lean forward, nose over toes, and kind of lift a little bit and shift. So she could lift like that, or she could lean and scoot side to side. So lean forward and scoot side to side. So for some folks, they do better if they can lean forward and shifting. They can kind of scoot forward like so, or they can lean forward and shift. Okay? So we can do like so. Okay? We can also lean back and push the pelvis forward. Or if we have enough balance, we can lean forward and shift side to side, or lean forward and give them a little lift to get ourselves to the edge of the bed. Okay, thank you.
Maybe so.
Let's see. Hang on for just a minute. I think we're good. Now, we may see a client who has had a stroke and they may have paralysis or weakness on one side. So we teach the person to scoot the extremity that's weak. So if you're a hemi and you're in bed, and we'll say my right side is weak or paralyzed, and I don't have the strength to get to move it, we're going to teach them to scoop. And so the person would take their foot, scoop under the extremity, and move it. Okay? So we can use a scoop method for when we're moving, doing different transfers, when we're getting in the wheelchair and we need to reposition when we're getting out of bed. So for the hemi, I would have them use their good side to kind of help grab the rail or grab a mattress. They would first grab their hemi side and bring it across their body so it's not left behind. And I'd have them scoop their leg, and grab, and roll. And more than likely, I would be over here helping at the hip and the scapula, those larger joints. And they're going to hold the scoop leg as they push up on their left elbow, bring their leg down, and come into sitting. Okay? When it's time to get into bed, we would have them scoop, go down on elbow, and bring leg up. Now it's hard. A lot of times these people are very deconditioned. They're exhausted from having had a neuro insult. They maybe have generalized weakness from hanging out in bed for several days. So even the strong side can be impacted from the event because of general deconditioning. So sometimes scooping is hard work for them, so you may have to assist a little bit. Keep in mind, all these techniques, there can be varying levels of assistance required. It could be max assist, it could be contact guard or supervision, modified independent. Okay, when we're doing the training early on, we can anticipate there'll be some level of assistance. So all the technique styles can have varying levels of assistance required. These are just techniques I'm teaching, and we have to keep in mind to give the level of assistance that that person requires. So that's our bed models. Now we know that person, if they, we're doing transfer training with them, often we're going to find them bed level and get them out of bed, and maybe doing ADLs, and they've got to get out of bed to get in the chair to do ADLs, or we're doing bed level ADLs, which is appropriate too. So bed mobility is crucial for us. Okay. I'm going to show you how to use the mechanical lift. There are different types of mechanical lifts. Some people call them Hoyer lifts. Those of us who are old school, Hoyer was a huge brand that was used. Now there's lots of different opportunities and different brands. There are lifts that do everything for you. There are lifts that don't require the patient to engage at all. And there are also lifts that we can use that require weight bearing. So it's a little bit different. We have one list here we're not going to use today. We have too much to cover. But it gives a person an opportunity to come into squat or full standing for transfer. So like a little sling goes around. Anybody seen those? The good thing about those is they offer opportunity for weight bearing, and they get proprioceptive feedback. So it's good. So if a person has the potential to do a stand pivot or a squat pivot, or you just research has shown that it's beneficial anyway because people weight bear. So what happens when we don't weight bear? We lose bone density. We start getting osteoporotic. So it's good for people to be able to weight bear if they can tolerate it. Some people can't, like they can't hold trunk or head up, and they're not appropriate. Okay. I need a person to volunteer. Does everybody offer at once?
I will.
Come on, Raymond. Are you doing that because I went to the hospital with you? Trade off. You can get over here on the mat. Now, we're going to have to use this a little different because there's a bunch of stuff under our mat. PT sparred our space because they had stuff stacked too high for safety reasons in their storage closets. Some of our stuff's under the bed, so we're going to have to do it a little differently. You can lay down, dear. Okay, so this mechanical lift is used for dependent transfers. So I have a client who right now doesn't have a sitting balance. They're a total assist. They don't have a sitting balance set on the edge of the bed. Maybe they can't tolerate weight bearing through their lowers yet. And I want to get them out. This is not therapeutic, by the way. This has no benefit for retraining. This is for convenience sake, to safely get someone into a chair. And so you will experience this if you're in a SNF. More likely you may experience it in rehab. So you've got, I've had patients who have been 400 to 500 pounds, and it takes 6 of us to move them, and it's just crazy, so we'll use a lift until they can become a little more independent. Okay, so this typically will go under the surface that you're transferring. There are different size lift pads. We just have one for learning purposes, but usually it would match the person's size. Some places the person has their own pad, other places just wash them in between. Sometimes it's a challenge to get the pad if there's only 3 or 4 and they've used 3 or 4 that day. So you're going to kind of do it like the sheep, except with this one we have a place for her head. We have a little head support. You'll see the different color bands, and that would depend on how snug I needed it up against the device, depending on how large she is. So we're going to get this ready. We'll tell Lainey, we're going to put a sling under you so you can get out of bed today. We're going to use the lift. Remember that? You loved it. Most people don't love it because it's scary for them. So I'm going to look at the material I have and plan for this to be under her head. On that, on the bed. And I would prepare Lainey. Lainey, we're going to roll so I get this under you. So if she can move her leg, whatever she's got, I want her to use. If she can move her leg, and I say reach across your body, great. Otherwise, I can push her from the points of larger joints that we were talking about. This under Lainey, get it tucked under here a little bit. Lainey, you can roll back for me. Good. Let's roll this way. Bend this leg. Reach over towards me. then these go between her legs. When you guys come to next lab, make sure you wear closed-toed shoes. Okay? When you have open-toed shoes, which you can't wear to work anyway, when we do this stuff in lab, if somebody could step on you, you could slide off your shoe, and that's not good when you slide off your shoe. Lots of people wear the Dansko kind of shoes. They're great for rolling your, I wear them, I have them, but you gotta watch out when you're wearing them, especially when you're transferring, because you can roll your heel out of, or your ankle out of them. I've done it before, rolled right off of it. And actually injured my leg pretty bad, wearing them. It wasn't at work, and I rolled off of them. So just be careful. So flip-flops you don't wanna wear. You can wear like your typical nursing shoes or Danskos or tennis shoes. If you wear shoes that have an open back, which most places won't let you, you can easily come off of your shoe when you're trying to transfer. So you don't want to do that. Okay, so we're going to get this into position. This goes under the bed or wherever you're transferring from. Back in the day, they were mechanical. Thank goodness we have the electronic ones that most facilities that have any kind of resources have now. We're going to lower this to her. Lainey, I'm going to bring this down to you, and then I'm going to put the straps on it, okay?
Okay.
They have fancier versions that you can actually weigh people on and things like that now. So I'm going to bring this down as far as I need it. Put the strap over. Give her. And this kind of catches it, holds it down so it doesn't slip back out. Anybody ever used one of these? So, Alex is like, okay, I can do this, I'm a pro. I can help her. She can help her. Okay, so I've got it ready to go. Okay. Now, I would have prepared the environment too. The chair would be wherever I need it to be to safely transfer into it. Now, you want to avoid like doing a dance with this. You don't want it in the middle of the floor where you're doing 360 degrees because you never know what's going to happen. Sometimes the batteries die. And then you're like, okay. So you might have to call for assistance, you know, and have actually move the chair back where the person is. So you don't want it in the middle of the floor is my point. You want it close to where the transfer. How's Pete, by the way? Good. Okay, so we're going to lift Miss Lainey up.
How'd you know to put it in the room?
I just kind of guesstimate by the person's size. She probably could have done a green. Now, you okay, Lainey? See, this is starting to come up around her head. She's going to feel like she's slipping out of it. It's kind of scary. I have done these by myself before. I don't recommend it. I don't like to because I like to have someone kind of directing the sling as the person goes, having their hands on, and you never know when you get in a jam.
What if these things rip?
I've never seen that happen. If they do, you're in
You're fine.
a bunch of duty. And then I'm going to pull it out. And I'm not going to force her around. I'm going to get her spine here to the end. Now,
Sounds like Lady Gaga and Egg.
start singing. Then we have a handle here that will open the legs. So the legs are kind of close together when I'm under the furniture, but when I want to go to the chair or the device I'm transferring to, I'm going to open the legs. Okay. When this comes in, this is when a second person coming in is helpful, and this will turn. When I want to get Lainey in position, so I would have someone come over, and I want to be in control of how she's positioned. So I would likely say, Rehab aide, can you come help?
Yes.
And I'm going to watch her legs. I'm just going to watch to where we've got her. Now I'm going to pull her back a little bit, and then we can lower her. So if I put her in the chair like this isn't optimal, is it? So I'm going to get her, maybe move this in. I make sure my brakes are locked, and they are. Those are kind of loose brakes, that's why I went. And I'm going to say, start lowering her, please. Lainey, I'm going to put you in your chair. And I may do a little facilitation. I may kind of move the pad and her, and the chair should not be moving where I want her. Go ahead and lower all the way in. Makes you like a lady, doesn't it? It's like going to the gynecologist.
Good?
Yeah. Now lower, you'll also have to watch for their head. I need enough tension to be removed so I can get the straps off. But I have to watch for her head. So as soon as I can, okay, I think we're good. As soon as I can get the straps off, I have the person stop because I don't want to hit Some facilities will leave the pads under the person. Bad idea. It bunches up, and when we have creases and bunches, what's that gonna do? Cause pressure and everything. So we want to take it out from under her. You can get them on and off in a wheelchair. And we'll see that in just a minute, so as soon as I figure out how to get this off. Okay, so we're gonna get this off of the unit. And I would ask my lovely rehab aide just a little bit to, let's see how we go. I'll ask my lovely rehab aide to move it. Okay, we're ready. You can pull it out, please, Lynn. And then when you get it out front, you can close the legs. So it takes up less room. Okay, so I'm going to take this off of my client now. You don't ever want to pull fabric from under a person because it's called shearing. And we don't want to shear anybody's skin. We don't want to cause the skin problems. Okay. And I'm going to move this out of the way. Don't go away, helper. Okay, Miss Lane, I'm going to move this out from under you. So it's relatively easy to move it out without pulling on it. Now you can see she's not in a very good position. I tried to get her in position. This is one way we can do it. Is to I'm gonna have Lainey lean forward if I can. Put her arms across her body. We're gonna do a two-man lift in just a minute. And you're gonna grab her lowers. And on the count of three, we're gonna scoot her back. 1, 2, 3. Get her in position. Easy breathing. Now she's beautiful. Right? Okay. So that's your foyer transfer. Amy. Lainey, what's there? We're going to get our lovely, lovely Kayla in the chair. You think you're Pam. So that was a dependent transfer that we just did. And so we're going to do a dependent transfer from wheelchair to bed. Make sure we're locked. All the other transfers we do, the chair is going to be at a 90-degree angle. This chair is going to be parallel to the surface because it's a dependent transfer, and I want her to go from this surface to the other. Maybe it's the mat, maybe it's the bed. But when we're having a person transfer train, we want to have a chair at a 30-degree angle towards the area we're transferring. Okay. So this is a dependent two-man lift. Okay. So the lift's not available to me. Maybe someone else has it. Maybe the battery's dead. Maybe she's afraid of it, and I've got to get her on the mat for therapy. And so PT and I are going to do a transfer. So the PT's going to come over here. She's going to squat down and grab. You guys probably want to come over where you can see. Grab Kayla's legs. Okay. I'm going to have Kayla cross her arms if she can. If she cannot, I'll do it for her. Come under her armpits. Grab her arms for stability. Kayla, on the count of 3, we're going to lift you and place you on the mat. 1, 2, 3. All right, need to lay down.
What about taking the arm off?
If you can remove the armrest, it's beneficial in the event that she starts squirming or yelling, or you feel it slipping. You can set her down quickly without worrying. One reason that it's not critical like it is with most other kinds of transfers is we have to raise her up over this anyway. But it certainly won't hurt, and I always remove leg rest and arm rest for transfers anyway, for all other kind of mobility, except if the person needs the armrest to push from, we would sometimes allow them to do that. But if a person's stand pivot or squat pivot, I move these typically. It's beneficial because, again, if we have to sit suddenly and she's right here, we're just dealing with the tire, but we have to raise her up above this surface anyway, so it wouldn't be a negative if you didn't. And you'll see them in some of the books and videos that they're not removed, but I like to remove things for safety. So that was a 2-man dependent lift. Okay? All right. You want to sit up from the edge of that for me? So she's in well. The kind of therapy she has is just so good that she's just doing so well. Okay. We're going to do a dependent transfer with one person. I don't like to use this. You'll see it used a lot with spinal cord injured patients. It can be any kind of deficit. We'll put the gait ball on teeth first. snug. I always ask the client, is that too tight? Okay, good. If she was to stand, it would loosen up, so we want to make sure it's nice and snug. I can get a couple fingers under it. So this is a dependent one-man transfer. Going to prepare the environment. I have it at a 30-degree angle towards me. I'm going to move the armrest, and this one's a little bit different. This one pulls up, I believe. Oops. Oh yeah, it does. But that's not what we were trying to do. Look at this chair. Now they're all a little bit different. All the chairs we have, this is one of the newer chairs, and I have to figure out how to lift it up. Get it. So this one you just pull straight up. Get it out. Okay. So it's at an angle. How close do you get the chair? As close as you safely can, so that both of you can move. So there's room for my legs and her legs. And so I might step in a little bit and look and see, hey, do I have enough room? You want the person's heels in the direction of transfer. Doesn't mean you twist their legs and make their heels point. It just means that their toes aren't going that direction. If our toes were going in the direction, she would look like this. And I couldn't transfer and it wouldn't make sense. So heels in the direction of transfer. So I'm going to scoot her to the edge or let her scoot herself. And I like to get people as close to where I'm going so I have less work to do. So I would scoot her over or have her scoot herself if she could. Now, with this type transfer, it's the only time you're going to have the client look away from where they're going with a dependent one-man transfer. So Kayla's going to look in this direction. I'm going to have her lean forward. I'm going to come over her. Now I'm going to take my legs and lock her legs. There are a couple ways that you can do this. When a person doesn't have the ability to tolerate weight through their extremities, and their knees will buckle, right? So if her knee extensors are weak or her quads, as I move her, her legs could slip out from under her. So what am I going to do about that? Some people will actually do knee to knee, tibia to tibia, and do the transfer. I don't like it. Especially if I'm tall and you're not. I'm way down here trying to get your knees. It's hard for me to move and keep your knees stable at the same time. So for people who can't put weight through their legs, are likely to buckle, they're not participating in the transfer from a lower extremity standpoint. I like to get on each side and I can control this. Watch me, I can tighten up on her. So if I really feel her giving a lot, I can give a good input on each side of her knees, right? Let's scoot this back to Smith because I feel like I can't move. If we started to fall, I would not have anywhere to move. So I tighten around the knees, have her look the opposite direction. Kylie, we're going to get over here. Kayla, we're going to get over in the chair on the count of 3. 1, you don't have to do anything. 2, 3. And then we transfer. So I give a little squat. Okay, I'm going to go this way again. Give a little squat, have her look in the opposite direction of transfer. I'm over her, count of 3. 1, I squat. 2, 3, I'm using my quads, not my back. We got the transfer done. Okay? I've never used that my whole career. I don't feel safe with it. Where the head goes, the body follows. So if she has poor balance and her head's going this direction and she's fearful too, and I'm lifting her, what direction is she going to go? She's going to go forward. So if I have good control, she's little, I'm not worried about her. Have someone who's much larger, that would be challenging, wouldn't it? But it is used and it's perfectly acceptable. You just have to determine whether you're safe with doing the transfer like that. I do a little different total assist transfer, dependent transfer, which we'll learn about a little bit later. But that's one of the techniques that you need to know. Thank you for being my victim. Let's see. I think we're going to stop here and try what we've just done, and then we'll see what kind of time we have to move forward to some of the other transfers. Okay. Let's see.
There's the girl button again, right?
Okay, I think that's it.